Good afternoon, everyone. Myself, Dr. Nikita Srivastava, Assistant Professor Urology at AIMS Bhopal, and I would be speaking on bladder dysfunction in pregnancy and postpartum. While this topic was given to me, an iconic scene from the famous sitcom Friends flashed in my mind, where one of the lead characters, Rachel, described her bladder habits in pregnancy in this way.
Oh, I have to go pee. Apparently this baby thinks that my bladder is a squeeze toy.
So, bladder in pregnancy can be aptly described as squeeze toy, leading to complaints of overactive bladder and urinary incontinence, predominantly stress urinary incontinence in pregnant and postpartum females. So, coming to overactive bladder, the incidence is whopping 41%, and the reasons are mostly physiological as well as inevitable. Owing to the close anatomical proximity of uterus and bladder, enlarging uterus might reduce bladder capacity by more than 100 ml till third trimester. Fetal head engagement further compresses urinary bladder and causes storage lower urinary tract symptoms. Increase in progesterone, increased GFR, and thus urine output, further leading to increased frequency. The effect of progesterone can be further explained with these tables by Karim et al. Increase in blood volume and cardiac output causes 50 to 60% increase in renal blood flow and hence GFR. While in purpurium, there is an increased shift of fluid from extravascular to intravascular space, thus increasing urine output. As the changes in bladder habits are mostly physiological and reversible, conservative management is effective in most of the cases, which includes modified fluid intake, reducing or stopping caffeine intake, pelvic floor exercises, and bladder retraining. Pelvic floor exercises would be discussed in detail under stress urinary incontinence section. As far as pharmacological management is concerned, oxybutynin has been widely studied but lacks data on safety. Intravaginal estrogens can be administered in postpartum females as they already have a decline in estrogen levels post delivery. Intravesical Botox is not commonly offered as there is a risk of retention and need of self catheterization after administration of Botox. Other modalities like percutaneous sacral nerve or tibial nerve stimulation are not preferred. Now, coming to stress urinary incontinence, which is involuntary loss of urine on effort or physical exertion, has a prevalence of 19% to 75%, making it the commonest type of urinary incontinence during pregnancy. Some of the obvious causes include higher maternal or fetal weight, muscular and neuromuscular injury to pelvic floor muscle weakness, either due to injury or due to smooth muscle relaxation caused by progesterone, or urethral incompetence due to urethral lengthening or direct damage to urethra and suburethral fascia. Though some degree of stress urinary incontinence in pregnancy is inevitable, it can be significantly reduced by practicing pelvic floor muscle exercises right since first trimester and continuing throughout the pregnancy and postpartum. Because pelvic floor muscle training strengthens the pelvic floor by elevation of levator plate to a permanently higher location, enhancing hypertrophy and stiffness of pelvic floor muscles and connective tissue, reducing muscle length and constricting levator hiatus. This is a very important table from Campbell, summarizing the correct way of performing pelvic floor muscle training. The women are instructed to contract their anal sphincter without contracting abdominal muscles in two ways. Firstly, contracting for 1 to 2 seconds and immediately releasing. Secondly, sustaining the contraction for 5 counts up to 10 seconds and releasing for some amount of time. Both of these exercises are to be performed 5 times in lying down, 5 times in sitting, and 5 times in standing position, 2 times a day, making it a total of 60 exercises. there are some strict don'ts in performing these exercises. It should be made sure to not contract abdominal muscles and gluteal muscles and not holding breath. The best way to make it sure is by performing simultaneous rectal and perineal examination by concerned healthcare professional while teaching PFMT. Biofeedback, if available, also serves as an excellent teaching tool. Here I would like to share another table from Campbell which explains the neck maneuver. The technique is to tighten the pelvic floor at the time of anticipated time of leak, like at the time of coughing, sneezing, or standing up. It can be also summarized as squeeze before you sneeze. Other exercises during pelvic floor muscle training are bridge pose, which is also known as Setu Bandhasana, wide-legged squat or Malasana, and cat and cow pose. But the thing to remember here is that PFMT is more effective in early pregnancy in continent women. If incontinence is already set in, the effectiveness of PFMT is questionable. As per NICE guidelines, intravaginal or intraurethral devices in pregnancy are not recommended. Surgical management such as slings or colpo suspension are not recommended until the family of the female is complete. For females not responding to conservative management and who have not yet completed their families, periurethral bladder neck injections with bulking agents is a good option. Now the last entity which I am going to discuss here is postpartum urinary retention, which we all must have seen at least once in our practice. Normally, a postpartum female voids within 6 hours of vaginal delivery. Also, a PVR of less than 150 ml is considered normal. So, any postpartum female not fulfilling these criteria are classified into PUR, which can be classified under these three categories. Overt PUR, that is, inability to void 6 hours after a vaginal delivery, or alternatively, inability to void 6 hours after catheter removal following a cesarean delivery. Covert PUR, that is having urinary symptoms or a post-void residue volume of greater than or equal to 150 ml after a spontaneous void as measured by ultrasound or catheterization, or persistent PUR, which is urinary retention lasting longer than 3 days postpartum and requiring catheterization. These are some of the clinical features suggesting postpartum urinary retention. Pathophysiology includes various physiological, neurological, and mechanical causes, some of which are also responsible for stress urinary incontinence and overactive bladder. One of the interesting predisposing factors is retroverted uterus, which can be seen in 14 to 18 weeks of pregnancy and is more common in cases of previously existing pelvic adhesions, deep sacral concavity, and uterine malformations. In most of the cases, urinary retention resolves as the uterus grows and exits the pelvis. Rarely, if retroversion not resolves, the fundus of uterus will need to be freed from the sacral hollow vaginally under anesthesia. The King College Hospital in London devised a VESSI questionnaire to identify women at risk of urinary retention, which includes questions like: has the female passed a good volume of urine after delivery? Does her bladder feel empty at the end? Does she have a sensation that she wants to pass urine? Was her stream normal? And was there any incontinence? This flow chart shows the trial without catheter protocol given by the same institute. If a woman has voided but the VESSI questionnaire suggests retention, PVR assessment should be done. Ideally, PVR assessment should be done in all females post their delivery, after first time they have voided, or after first time they have voided, after the removal of catheter in case of a cesarean delivery. If post-void residue is 250 to 700 ml, she should be recatheterized and trial without catheter should be done in 24 hours. In patients with higher PVR, patient should be sent home with catheter for more than 2 weeks. Similar protocol to be followed in case if the woman is unable to void post-vaginal delivery or post-catheter removal after cesarean section. Also, if the voided volume is less than 150 ml, the causes of low urine output should be ruled out. So, if the failed trial without catheter continues even after 2 months, one should look for persistent retroverted uterus and other causes of urinary retention. Role of tamsulosin and methanocol is questionable. Maneuvers such as Valsalva and Crede may promote bladder emptying, but they lack evidence. To conclude, most of the voiding problems in pregnancy are reversible. Preemptive scheduling of pelvic floor muscle exercises and bladder training would help in reducing the possibility of voiding dysfunction in pregnancy. These are my references. Thank you.